My name is Alberto Murino. I'm a consultant gastroenterologist at the Royal Free Hospital in London.
And I'm Edward Despott, the endoscopy lead for the Royal Free Unit for Endoscopy here in London.
It's a great pleasure for us to discuss our recently published study in gastrointestinal endoscopy entitled Multicenter cohort study of patients with Barrett bumper syndrome treated endoscopically with a novel dedicated device.
Yes, and this, as you say, Alberto, is a multi-center study, so we are here on behalf of all our fantastic collaborators. There were 13 centers from all over Europe and the UK who have kindly helped to pile up this data and outcomes. So, fortunately, as you know, Barrett bumper syndrome can be a very tricky complication of peg insertion. Fortunately, it's rare. It happens in less than 1%, but when it happens, it can lead to suffering and a tricky situation because the granulation tissue which envelopes or grows over the bumper, hence the word Barrett bumper syndrome, can lead to abscess formation and more commonly blockage of the actual feeding site, so there's failure of feeding. And although the literature has a lot of publications relating to ways of removing this, many a time there's heterogeneity in terms of techniques used. You can use a snare, you can use a balloon, you can attempt to remove this with a needle knife or an ESD knife, and some people have also used a sphincterotome. But there has never been a single dedicated device for us to be able to remove it. So this is why we're excited to present this data.
Yes, because it's now this procedure is more straightforward, and the flamingo is basically the shape of a flamingo neck, which has a cutting wire in the middle. So we cut the peg externally, we insert the device, and once the device is inside the stomach under direct endoscopic visualization, and you therefore need two endoscopists, you basically pull the flamingo device externally, it bent, and then you pull it towards the granulation tissue that cover the bumper, and you make some radial or star shapes around the.
So essentially, if I were to understand it as you are describing it, it is shaped similarly to a sphincterotome, hence why the neck of the flamingo, and it's got a bowstring wire, and by pulling this into the granulation tissue and activating diathermy, you make radial cuts and free out the bumper.
Exactly.
Okay. So Alberto, tell us a bit more about the cohort of patients we've studied, about the success rates, what were the endpoints, and if there were any complications or any issues.
So we involved 55 patients in this study. The first primary point was to assess the success of the treatment of the Barrett bumper syndrome with this device, and I have to say we had a success in 53 patients out of 55, so 96%. And as you know, we had a failure in 2 patients. But
and the failures were really technical mostly, because one, as this is a sheet of plastic, sometimes they malfunction, so it was a bit of a malfunction in the device in one of them. And the second patient, as you know, sometimes the Barrett bumper gets pulled in so deep into the stomach wall that it involved the muscularis propria. So that's not appropriate to be removed endoscopically. You need a surgical procedure for that, because you'll end up automatically with a perforation if you try, or a long-term gastrocutaneous fistula.
Indeed.
So when it was successful, tell us a bit more.
So when it was successful, we also record the timing of the procedure, and on average it took 22 minutes, so between 5 to 60 minutes. So it looks like it's quicker than previous report that show the management of this syndrome with multiple techniques or devices. So then we recorded the complication, so peri-procedure complication and post-procedure complication. The peri-procedure complication were 4 cases of bleeding treated endoscopically and resolved endoscopically. 2 perforation. One was treated with clips and one conservative management with resolved afterwards. And then there was, in one case, the GOJ, gastroesophageal junction, was lacerated with during the remotion of the peg.
The peg itself.
So it's really minor complication.
Okay.
And then I think we had 2 post-procedure complications that occur within 48 hours after the peg removal, and there were sepsis in 2 cases treated with antibiotics.
In fact, we tend to advocate the use of antibiotics mostly whenever we're going to attempt removal of a buried bumper, just because there's always that risk. What about the feasibility of inserting the peg during the same procedure?
That's a very good point, because we want to try to place the peg on the same procedure so that the patient doesn't have multiple procedures. So 44 out of 55 patients, so 83%, they had the peg placed on the same procedure, and 35 of which using the same fistula. So take-home messages from our study.
Take-home messages, Alberto. I think this demonstrates that a single device with purpose, so designed to remove or at least treat this tricky complication, has been shown in our multicenter study to be feasible, relatively safe, effective. It has potential advantages in terms of time, potential advantages in potentially reducing the number of devices used, accessories used, and I think it holds promise, and we look forward to seeing further data from other centers which may confirm our experience. And we also wish to thank all the collaborators of this study, because without their contribution we wouldn't have been able to mount such a robust amount of data in relation to this device. Thank you.
Indeed. Thank you for the attention.